All right.
So, David, welcome to Bridges in Science. You are the first guest. It's an
Thank you.
honor for you. And it's very great to have you after all this year. We didn't see you maybe for 20 years, almost.
I know. It's, you
And,
look great, and I'm
yeah,
glad everything's going well.
well, perfect. After some time now. So, David, you need no introduction actually, but I feel compelled to do so because so many people are not familiar with your career and achievement. You are a professor of urology and radiation oncology. You are the former head and the founder of urologic oncology department at the University of Colorado. You are an active clinician, researcher, and teacher. Your career almost spanning 5 decades.
Oh man, don't tell me that.
Yeah. You graduated from Cincinnati University in 1973, and you completed your residency program at the same university before moving to California. You are now back in California after so many years. So you completed your fellowship in urologic oncology. Maybe you are the first generation to do this fellowship in US, probably. So you completed that under the auspices of Dr. Donald Skinner. We will talk about him later, at the University of California Medical Center, LA. And you are the author and co-author of more than 600 published articles. You contributed nearly to 100 educational books. You provided thousands of educational talks for patients and physicians. You are the recipient of 95 research grants in the diagnosis and treatment of prostate cancer and other prostate conditions. You performed thousands of urologic oncological procedures, in particular radical prostatectomy, and you have your own technique, which is very famous. You trained hundreds of residents and fellows from US and from around the world. Some of them are currently holding key positions in the field of urology and urologic oncology. Your approach to training fellow was the original one because you're offering a comprehensive program, including rotation to surgery, radiation therapy, medical oncology, and you encouraged fellows to take part in research and authoring original articles and book chapters. You hold a weekly second opinion meeting to discuss different oncology cases with a panel of experts. This kind of meeting which offer multidisciplinary approach to patient condition and tailor the treatment to the special needs. You are the founder of the Prostate Condition Educational Council, and you a nonprofit organization which is responsible for reaching to more than 400 million people each year with education and awareness information. You are often requested to act as an educator, speaker, and participate in advisory boards, review research, and serve as legal expert. You have been recognized as one of the best doctors in America and one of the 20 urologists, top 20 urologists of the country by Man Health magazine, actually. You are an active member of many national and international organizations, including American Society of Clinical Oncology and American Urologic Association and American Association of Advancement of Science. The list goes on and on, and we cannot get to the bottom of it. Dr. Crawford, welcome to Bridges in Science. It's a pleasure to have you tonight.
Jen, thank you very much for this honor and that very detailed introduction. I sort of need that. I've been under house arrest here with this COVID-19, and so it's good to hear about stuff. And before I begin, I want to say I'm very proud of all your achievements and the things that you've done. And our time together was very valuable, and we accomplished a lot, and I won't forget that.
Thank you very much, David. Congratulations first with your new position at the University of San Diego. Tell me how are you going along with the new team?
Yeah, sure. You know, as you said, I've been around Colorado for a long time, and underwent this phased retirement. And so that sort of came on very quickly, the 5 years of being phased to phased retirement. And I still felt like I had a lot of energy left and things to do. And I was very fortunate to have the opportunity to associate with a great group out here at University of California, San Diego and La Jolla, with Chris Kane and Manoj Manga, who just came here as the chief of urology, and Kelly Parsons and Kareem Kadar and a whole group. And so it's offered me the opportunity to continue some very specific areas of interest that I have with targeted therapy and prostate cancer and the evaluation.
That's great. At the beginning, we cannot afford to skip the question you just mentioned about the lockdown. This question is dictated by the current event in the whole world in the United States. The whole world is going through a difficult time due to this pandemic and its economic and political fallout. So how have you been coping with this lately? How you're dealing with the patient overload, and how have you caring for the patient in this particular time? Did that impact your daily practice?
Yeah, it's been a very challenging and difficult time, as you well know, around the world, and it really caught a lot of us by surprise. I think that there has been a lot of good things done, but there's also been a lot of overreaction and a lot of people, mandates and different politicians and things like that have had an effect. But I think we'll pull through it. I like to look at the positive things and that happen, and I think there are some positive things that have happened with this. It really sort of unearths some of the challenges in our healthcare system, but also it opened the opportunity for maybe delivering better care with a wider group of people with telemedicine.
We'll talk later about it. Yeah,
it's it makes getting people to develop platforms to relax some of the legislation and rules and regulations about this. There's a lot of worry about practicing medicine across state lines like Nevada, California. Right. And that sort of was led up so that, we have more uniform legislation now. Or
maybe across the world now. Probably it will be across the world, not only states in US. It will.
I've spent a lot of time, as you well know, as editor-in-chief of Grand Rounds in Urology, and we're going to talk about that. Mm-hmm. But we have a whole group of discussions about COVID-19 and how to set up telemedicine and how to deal with people and things like that. So it's been a very interesting time, and it's also, I think, probably half of urology can be covered by telemedicine.
Sure,
and and actually patients like it now. They don't have to come and find a parking spot and wait and that. So there's a lot of advantages, and but it has had an impact on us. There's no question. We're just starting to get revved up again, and it's hurt a lot of businesses, as you well know, and things around the world. Travel, airlines.
Yeah, sure. There was also some report on, obviously, there is some overreaction sometimes. Sometimes there is some laxity in dealing with the issue. But there was also concern in the medical community. There was this report from Lancet, which cast a lot of doubt and loss of credibility for some respected journal and some medical authorities by just really publishing something hastily like this and casting some doubt about the result from this old drug for treating the COVID-19, yes,
yeah.
hydroxychloroquine. So what do you think of that? Well, your reaction to that, and how can we restore the credibility, and how can we escape interference from special interests and break free from this conflicts of interest? If you,
That's a very tough thing. I think what's happened is some of the major journals like JAMA and JAMA Oncology, and you're talking about Lancet and New England Journal of Medicine and others have really revved up the reports of all the aspects of COVID-19. And if you look at New England Journal of Medicine, it's the journal is sort of overwhelmed with people's opinions, and I think we, when we're trying to rush stuff, we lose some of the peer review, and you can't rush science sometimes. And this stuff about trying to get a vaccine, everybody wants that, but certain things have to proceed in phase 1, phase 2, and phase 3 tests that we've always done. People have said that, but there's this political rush, and economic rush,
pushing by the
and so it has had an impact. But it hasn't been. I don't think there's been a lot of bad articles published. I think that there's been a rush to get some results out, and there's opinions. And this one with Lancet was a problem, but I don't really think that it's ruined the credibility of Lancet or some of the journals unless it continues.
It tarnished it a little bit, but not really.
Right. Yeah.
Okay. But going back to your career, David, why did you choose to become a urologist? And when did you find out that you have a special interest in urologic oncology?
Well, then when I went to medical school, I came from a family that didn't have a lot of money, so to speak. So I had to sort of work my way through medical school. And I was on a scholarship, but I still was married with some kids in medical school. And so both my wife and I worked. But one of the things that I did was I did histories and physicals for a urologist, and got to see urology, and that you were dealing with young kids, teenagers, adults. You were dealing with a lot of different things, a lot of technology, and you know what? Most of the people we take care of, we help, and they cure a lot of people. And then, so that's how I got interested in urology. And then my Dr. Skinner, as you had mentioned earlier, at the time I went to residency, we didn't travel a lot to meetings like our residents do now. I got to go to one meeting during my residency, and I drove from Cincinnati to Cleveland, Ohio, which is probably about a 6-hour drive, to go to the Cleveland Clinic and listen to a presentation on oncology. And that's where I met Dr. Skinner, and this guy is really on the cutting edge of making a change. And so I basically approached him about being a fellow, and there weren't fellows a lot then. Memorial had a fellowship, MD Anderson, but most of the programs didn't have fellowships in oncology. So I was able to pester him enough that he took me in, and I became a fellow in his program. So that was really a great thing to have the opportunity to do.
And how working with him impacted your career later?
He was just and still is an unbelievable surgeon trained at Boston. And he really opened up the whole, he, along with Donahue, the cure of testis cancer early on, and he was into bladder cancer and
bladder cancer. Yes,
we do 3 or 4 retroperitoneal node dissections a week, and cystectomies and so forth. And he was an innovator. Surgically, he was, a perfectionist, and it was a great opportunity for me. And along with me, at UCLA were a lot of giants in urology still. That now we have Peter Scardino, who is head of surgery and at Memorial.
Yeah.
And was there. He was head of urology at Baylor before he came there.
Yes.
And then Lenny Marks and a whole bunch of other people. Dr. Walsh was there before. He wasn't there when I was there, but just had left. And so there's a lot of great people that came out of that program.
Okay. We know from history that the discovery of cystoscope made urology separate from general surgery. So currently, what do you see the most important watershed in the history of urology that made difference with earlier generation of urologists?
Well, urology has been blessed with a lot of technology that has made a difference. And you mentioned cystoscopy. And, when I trained, they were just basically light bulbs, not fiber optic. And we didn't have cameras. And so the professor would do a resection and you look over his shoulder and then you look and, that changed a lot, the whole education. And there's a lot of things that have happened in urology that have been important. I think we can be proud of things like the first tumor marker in oncology was with us, and that's acid phosphatase. The first effective therapy oral for cancer was estrogens, and the most important tumor marker is PSA. And it goes, the LHRH agonists. There's been Nobel Prizes and things like that, but things that have happened that when I sort of trained, the most common operation we did was a TUR.
Yeah.
Now we don't do many anymore. At least we don't. We have made a lot of progress there. We also had a lot of stones, open stone cases and things like that. Well, we know that ESWL and PERC and all those things eliminated that.
Yeah.
We were early adopters of laparoscopy and robots and things like that. And now we have where the blessings in advanced prostate cancer of having drugs that are all different. They work. We have immunotherapy. We're going to see marked changes in survival rates, and we're already seeing them. I think we're going to see, I've done 4,000 radical prostatectomies in my life, but I don't really need to do any more.
Yeah.
And I say that from the standpoint of we aren't going to be doing that so much anymore because we have immunotherapy and other things that are an option here. You don't need your prostate except for fertility. So there's a lot of antigens you can go after, PSA, PSMA, acid phosphatase and things like that. So I think that we're not going to be doing as many radical
prostatectomy in the future. Sure.
Yeah.
The technology is a good thing in urology, but there is a gap between developing and developed country. And sometimes inside the same developed country, you have a difference between regions. So how can we solve that? In your opinion, I think there is a lot of factor involved. You cannot solve that with the single word or the magic. So it's your opinion. I get.
There have been a lot of things that have come along in urology that they're innovative, and some of them make it and some of them don't. And there's been a lot of gimmicks. I mean, we can focus on various things, but prostate BPH and heating it up and freezing it and injecting it and Botox and one thing after another. And that, it trickles down to what really kind of works. And we're sort of seeing that right now in the area of BPH with using things like Resume, the water vapor, and using things that UroLift. Who would have thought something like UroLift would be valuable?
Right. Let's move to your special interest, David, which is prostate cancer mostly. You have the initiator of Prostate Cancer Awareness Week. There was a large adhesion from general public to the idea. What is your current position on mass screening?
Well, I think my interest in early detection was the fact that there wasn't any, and that most cases of advanced prostate cancer that were diagnosed were advanced and incurable. And but we had, you know, we did have some parallels in breast cancer with mammography and things like that. And breast cancer, I've already said, is 10 to 20 years ahead of us. And so, you know, that was approved for Medicare to pay for mammography and things like that, which got us into the PSA, which, you know, I remember when Paul Lang, who's a urologist in Seattle, University of Washington, called me many decades ago. He said, we got this test called PSA, and it's able to predict when people fail radical prostatectomy or radiation. I'm going, what are you talking about? And, you know, and that led to, we got involved with early detection, Catalona and Mike Brower and others on using PSA, and we didn't know how to use it. I mean, and you know what, when we first started screening, it was tough to get anybody to help us. Yeah. And it was tough to get a spokesperson, but we did. It was successful. The problem was it was too successful. We found the advanced cases. We got sort of rid of them, but then we were finding ones that we thought we were going to help. And then we realized that if you take 1,000 men age 70 and take their prostates out, or, you know, when they die or something of another cause, we find 40% risk of prostate cancer. And we were starting to find those, and that was the overdiagnosis and overtreatment. And then that got carried away, as you well know, with robots and with different forms of irradiation, and we were overdiagnosis and overtreating, and that led to the U.S. Services Preventive Task Force, which was an organization that was put together by the government to advise family practice docs on screening and blood pressure levels and things like that. And so what they showed was that we were harming more people than we were helping. And so I agreed with what they came out with. They said, hey, we need to hit the pause button here and stop for a while and figure out what's going on. And you know, so what's happened to make this all work now is that we have molecular markers that help us determine who should be biopsied. A lot of us are proud of the fact that we're putting a lot of people on active surveillance. I don't want to find patients for active surveillance. I want to find patients who need to be treated. I want to eliminate active surveillance. I want to eliminate low-grade cancers, Gleason 6s. And so, you know, the good thing is we have markers now. We've got algorithms, and we have MRI and lots of other things to help us find people that need to be treated.
I want to ask you about PSA, but you answered my question before that. I'll ask you that. So the grading prostate cancer is a serious business. And we remember late Gary Miller, how he was very meticulous about reviewing slides. So Gleason score is an element that stood the test of time. Recent amendment has been made to this score, and the score 2 to 5 almost now are no longer assigned to certain pattern initially defined as a core 6, and some 6 are upgraded to 7. So what do you think of this amendment? Is it good or not good?
Well, I think you just said it. The Gleason score has maintained its value over decades. And it was actually brilliant over, you know, low grade, intermediate, and high grade. And what it did is it looked at the 5, you know, patterns, and then you know, that you looked at the primary and then secondary, you add it together and you got a Gleason sum. And the worst can be 10 and the best would be 2. Sure. Well, then we realized we never solved the turning point was 6. And, you know, we didn't see 3s and 4s we didn't see 2s and 3s because those are ones that we're seeing with open prostatectomies or large BPH or TUR. And so that led to when you see a patient and you say, well, you have a Gleason 6 cancer, and you say, we're going to watch it. Everything's fine, whatever. Well, they look at, okay, if this is a scale of 1 to 10, I'm a 6. I'm halfway to trouble.
Sure.
And so it really made sense to reassess how you categorize and grade groups. And a group of us, and I was one of the urologists that were part of that, got together in Chicago, gosh, just 5-10 years ago, and said, hey, we want to, along with Dr. Epstein, we want to reclassify, and we reclassified it as grade group 1 and 5. And so when the 1s were 6s, and then the 2s were 3 4s, and the 3s were 4 3s, and then and so forth. What it did is it, you know, we have a scoring system up to 5. When patients said, well, you're in group 1 or group 2, and we did, this is probably more of a toothless lion and less of a risk. So it made sense, but with Gleason score still used, it's just how you bucket them.
David, you witnessed the evolution of hormonal treatment from metastatic prostate cancer, from surgical castration to since the work of Charles Higgins, and later and afterward the discovery of LHRH, and which led to the Nobel Prize of Roger Galvin and Andrew Shelley and Rosalind Yallow for the discovery of agonist LHRH. The notion of hormone sensitivity is most of the time very short-lived duration and variable according to the degree of differentiation of cancer. You are the first to publish about that and about complete androgen blockade. There is still any indication for complete androgen blockade in hormone sensitive?
You know, I think that, I mean, just to step back here, we're blessed with hormone therapy in a way, because what other cancer can you have that somebody is writhing in pain, metastatic disease, blocked kidneys, urinary problems, and you can do a simple thing like, you know, remove their testicles or give them an injection and have sort of this miraculous turnaround.
Yeah.
So I think we have to, and the other thing is that we've got to get away from the whole concept that hormone therapy cannot cure some prostate cancers. We've shown it. And I asked urologists, can hormone therapy cure prostate cancer? And nobody says, and everybody says no. I said, wait a minute. We know that about 15% of people with metastatic disease, even bad, live 10, 15 years and die of something else. We call that a cure in some cancers. We know that when you combine hormone therapy with radiation, you can, in high-risk patients, you can improve survival rate. That's called a cure in these people. We did a study when you were around with positive lymph nodes, and we gave people hormone therapy versus delayed, and there was a big difference in 10-year survival rate. We've given it adjuvantly after surgery. So what we have, hormone therapy does do good, and people become resistant, but not always. I always see people that are out 10, 15 years. But what we've learned about hormone therapy is the side effects go beyond hot flashes, their weight gain, and the big one is cardiovascular, and that's an important thing right now. I've had the opportunity to work with Dr. Shalley in the last couple of years. We've written a couple of papers on cardiovascular and FSH, and the worst treatment for prostate cancer is bilateral orchiectomy. That's hard to believe because there's more cardiovascular events, and everybody thought that's not true. It is true. It's been shown, and it has to do with FSH and things like that. And so we're happy that we've done a lot of this, and we've got some new drugs coming out now. We have an oral antagonist that's out there that will probably be approved, and it's a daily pill. That's great. So it's you know, they have all these therapies that we have for prostate cancer, and all these new drugs.
I know you have your own opinion concerning the use of agonists or antagonists. So tell us a little bit if there is any fundamental difference between the two regarding the treatment of the patient, which one you choose and why.
We talked to Dr. Shalley, and when he was working with the idea of shutting down this axis, why would you want to stimulate it first versus just shut it down with an antagonist? And so that's where he started out, with an antagonist. And and then agonists could have some role, in some of the gynecological things where you didn't worry about flare and things like that. So what he found out is that the antagonist, it took a large volume, because you had to manipulate 8 of the 10 amino acids in the decapeptide, whereas leuprolide is just
one single
around
one.
with number 6, yeah. And so it was more difficult. And then there were sort of allergic reactions that occurred to him. And so that sort of, put that in the back burner. And then he found out that you have this paradoxical effect with an agonist. And so you make things worse before you make them better. So the idea is that, so if somebody has an elevated PSA, you put them on an agonist versus an antagonist. Is that little flare in testosterone bad? Well, it actually is. And there's no question that an antagonist is better, but you have to make a compromise. And what we did was add an anti-androgen to it. And that was called, as you mentioned, combined androgen blockade. And I must say that we had a 6-month survival benefit, 4 to 6 months in patients. That's a lot today. And so you asked me, is there a role for combined androgen blockade? Yes, there is. We should do it. We should continue to do it. A lot of the drugs we're using, the new drugs, lower testosterone more. And we have a paper coming out right now in Journal of Urology, just came out this month, that shows that we, with a lot of the injections, we have escapes. And that leads to rising testosterone and
the microsurge,
rising PSA. So it's called acute on chronic, or microsurges that occur. And so the goal of ADT is to lower testosterone and keep it down. And the lower, the better, less resistance that occurs. So, there's a role for combined androgen blockade. There's a role for antagonists. But the problem with antagonists has to do with, monthly dosing and
short duration.
Maybe you can block some of that with an anti-androgen, but it doesn't get away from the FSH issues.
Yeah, that's what I want to hear from you. The impacts on FSH. How did the agonists impact the FSH? And what's the role of FSH in stimulating the development of other cancer, maybe?
Well, we've been working with FSH for quite a while. It goes back to some work we had done with Dr. Ben Joseph and also with Dr. Porter. And then it's sort of this lagged around, but FSH is a mitogen. It stimulates prostate cancer growth. FSH receptors are in a lot of places in the body. And it's in bone and
colon,
it has, we think, the cardiovascular events. And so FSH levels are the highest in men who have bilateral orchiectomy. That's why bilateral orchiectomy has some problems. FSH levels go up with a agonist when you give it, it's a flare, and then when you re-inject, and some of it does. But if you look at studies that were done with Firmagon, Degarelix versus Lupron, what you see is the FSH levels are still lower with an antagonist. And so, but you have to offset that with the inconvenience of monthly injections. And so some people would start with one and then switch to another, or use an anti-androgen. So I think if somebody has prior cardiovascular disease, we have pretty good evidence that and this is there's more data coming out, monthly about the value of an antagonist over an agonist, unless you can really keep testosterone. Most of these side effects occur in the first few months. So if you can prevent these flare things that occur when you re-inject. Interesting, it's in the depot, like leuprolide acetate is 28 days, not 31 days. The 3-month is not 90 days, it's 81 days.
Or 12 weeks.
I know. It's the weeks aren't months. And so that can lead, everybody say, oh, what does that do? Well, it does lead to a problem.
Yeah. Okay. So we moved from hormone refractory notion to castrate resistant cancer. Can you please explain how we moved from one to the other? And this notion may come back maybe in hormone refractory after we exhausted the new therapy. How we call this? This is, again, it will come back again to the notion of hormone refractory. After using abiraterone, enzalutamide, and all this drug, the cancer is no longer responsive again. So the notion of castrate resistance as maybe played out. It's exhausted. You can no longer tell this cancer is not responsive anymore to the hormone. So you have to move something else. The hormonal option is exhausted. So what's your opinion?
Well, we could talk about that for an hour, but I think we'll just make it the short version. Obviously, there are a whole bunch of moving parts in what you just said, and that's very good. First of all, nomenclature. We called it androgen independent and hormone refractory. And when we got these new drugs out, abiraterone, enzalutamide, things like that, it was people said, well, they're not really
hormone refractory.
They're not really refractory, but they're resistant, and so that's the word, castrate resistant. But I think we're going to go back to the old terminology and we'll call it something different. Castrate resistant. Patients don't like the word castrate. They don't like the word resistant. We're publishing a paper, one of our radar papers on transition cancer, which is in between, locally advanced and castrate resistant or hormone refractory disease. So, the terminology it's sort of like the Gleason thing we just went through. It needs to be rebucketed. So that's something to think about. The other thing is that all these new drugs, what they do is they just squeeze, the testosterone down more, or they block it.
Yeah.
So first of all, why don't we make sure with the agents we use, primarily ADT, that we get it down and keep it down as low as possible? And what we see is a lot of the patients responding to some of these have testosterones that are not at castrate levels, less than 20, less than 50 is what the FDA says, but they're 30s. So maybe if we got them down more, we'd have, and that would not be so much of an issue. So, but, the good thing is it proves that prostate cancer along the way is still testosterone sensitive, but as you alluded to, eventually they'll fail these things, and we're getting smart. We're seeing ARV7 mutations. We're seeing other things. People were, I just interviewed Dan Petrolak about some drugs he's working with that downplay and destroy the androgen receptor and mutants of the androgen receptor and get response. So we're going to play around with that a long time, but I think that the future is, we see with all these drugs, they all started at the end of the line, people failing chemo. Now they're moving up to pre-chemo, newly diagnosed metastatic disease, non-metastatic castrate resistant, and so forth. And, cancer is a collection of genetic changes, and the longer it's around, the more genetic heterogeneity and less responsive it is to therapy. And so early is better, and that's what we're seeing all these drugs move up to. And I think we're gonna see improvements in outcome with that.
David, a decade ago, maybe, we didn't have a clear idea about the indication of the new therapies, abiraterone and enzalutamide, when to introduce them and how to sequence them. So now, do we have a clear idea when to introduce the drug and how to sequence them?
Well, no, yes and no. There have been studies done, and our RADAR 2 manuscript was was on, we called it therapeutic layering. All right. So we build on something. And what we have to have, the foundation of care is ADT. And, however you want to define that, combined androgen blockade with whatever one thing that. And then we build on that. And we build on it with abiraterone. We build on it with radium. We build on it with some of the third generation anti-androgens. And we've been doing this for a little bit, and it's catching on. Is hitting patients hard with more than one drug. I mean, when you think about it, the cancers we cure are not like testis cancer is not cisplatin alone. It's cisplatin, bleomycin, and Belban, or other combinations like that. You cure lymphomas not with Cytoxin, but with CHOP. Leukemias. So why do we think that we go treatment A followed by B followed by C in prostate? We want to put A, B, and C together. And I think we're starting to see that with doublets and triplets, and it's happening. So that's all good news. And I think that's where we're going to make progress. We're seeing that people get it, maybe 6 months, 7 months of treatment, then stop it. That's what we do in other cancers that we cure.
Yeah, sure.
You don't do it forever. And that was sort of intermittent therapy. We did that, but that was a whole different thing. We didn't have other things going with it.
What's your opinion regarding moving this drug earlier in the treatment? New drugs, moving them before the appearance of metastatic CRPC.
I think that's the future. I mean, that thing I just said about cancer being a collective or a series of changes that occur over time, and the longer it's around, the less responsive it is. So it makes sense. Early is better, and that's what we do with screening. I mean, we do radical prostatectomies because we think we found it early, and we're all good. So anyway,
the issue of the cost. How's going to pay? This drug is not free, right? It costs a lot of money.
Then that is an issue, but that's not my problem to figure out. We're scientists, and here's this is my iPhone here. Not too long ago, we had little Palm Pilots that were $400 that we'd keep our schedules in, and we were all excited about that, and so forth. And so now we have this iPhone or whatever Android device, and your whole life is on there. You have your calendar, you have your emails, you have 30,000 pictures, you have all this other things.
Bank account.
And, if you look at the individual components of this, it's, hundreds of thousands of dollars, yet you get it for, several $100s.
Yeah.
Well, I think that we're smart, and there's ways that we can reduce the cost of drugs and things like that. And so forth, and we have to. There's no question, but there is a lot of cost in developing that, and has to be recuperated. But we'll find a way. We'll find a way to make it happen. When the first ultrasound machines came out, they were expensive. The S-wall machines, and then you get them. You get technology, and you get the cost down.
Great, David. Let's go back a little bit to the education, and with this pandemic, we've seen the explosion of webinar. So I will just go back to the issue of telemedicine. How do you think telemedicine will participate in the education of young generation?
Well,
in the light of what we have seen now.
What telemedicine has to do with the doctor and the patient. Virtual meetings, I think that an education is what you're talking about, where we, like right now, instead of us interviewing with, you visiting me or I, visiting with you, it's over Zoom or some of these platforms like that. I think that's some of the good thing, but you know what? I think, everybody's all over the telemedicine stuff, and that's left and right, but it does serve a purpose right now. But I think we're going to go back to having live interactions. You can't live in a vacuum. The same way with people is that you actually lose your immunity if you're in a bubble all the time. You got to be out there and pick up those antigens that are around there. So I think people will get together again and have meetings. I think that we're planning on, we have a lot of meetings that we do. We're planning on doing hybrid meetings. So, I look at it like television. You have an audience, you have a show that you're putting on, a meeting, and then it's broadcast out if people want to watch it. And I think we're going to see more of that. But I don't think meetings are going to go away.
No, absolutely. Absolutely. David, you are the editor-in-chief of Grand Round in Urology. Please tell us about this platform and how urologists from outside US can benefit from the content or get an article accepted on.
Well, Grand Rounds in Urology has actually been around for about 35 years. What it started out with is to fill an unmet need of getting information out quickly to urologists in publication. So it was a publication. We had 2 or 3 articles in there, and there wasn't a lot of stuff back then, a lot of journals, and there wasn't a lot of textbooks and things like that. So that was really a way to do something quickly. We didn't have the web. We didn't have, we had Urology Times and things like that, and that was about it. So there was an unmet need. And then what happened was we've evolved to, web-based education and virtual and things we just talked about. So Grand Rounds in Urology became a website. And what we've done is develop it into learning centers. We have, next generation microbiome, next generation imaging, next generation ADT. And we populate it with great lectures called platinum lectures. And then we tend to, people don't want to spend an hour listening to a talking head anymore or a professor. They like short snippets, like 5 and 10 minutes, like
take home message.
Yep. And so that's what we've evolved into, 5 and 10 minute things, and then point counterpoints. And it's great. We're reaching 19,000 different people a week right now. We have about 4,000 urologists following us. Mm-hmm. We're opening up. I have a call this afternoon with a group in Southeast Asia and Hong Kong. So we have international. They're delivering a lot of things that are unique. They're doing in mainland China, Hong Kong, Singapore, things like this. That is expanding our audience. We would love to work with you and your colleagues to open up a site.
We appreciate it.
And you can be doing interviews like this there, and we get it, and it goes around the world. So we'll follow up on that. But I'm very proud of what's happening with Grand Rounds in Urology. We're balanced, and it's not just where the funding is. We tend to go where the science is and things like that. And so our group is outstanding, and it's growing by leaps and bounds every week.
David, it was a pleasure talking to you. I would have loved to continue with this discussion a little bit longer, but I know you have commitments.
Okay. We can do something later, and
certainly there will be episode 2 of this. Certainly, yeah. And we'll carry on with the rest of the issue we didn't cover in this meeting.
Yeah,
great, David. Thank you very much. That's very kind of you. Appreciate it.
All right. Take care.